happy to see so many of you joining us today. It is my honor to have such distinguished guests with us, and and Dr. Tunji Funsho and Michelle Zefran. Thank you for being with us. As we know, the first half of the 20th century was plagued by polio. It was the most feared disease, and since the implementation of the polio vaccine, we have almost eradicated polio. We saw a huge reduction in polio by 90% when vaccination occurred between the years 1955 and 1962. And I was thinking about this as I was researching. I remember standing in line. I think I was in kindergarten or first grade. I was 5 years old, and I had my permission slip, and I can remember this clearly, being in the cafeteria at St. Andre's Grammar School and getting in line to get the vaccine, the polio vaccine. I realized today how blessed I was at that time to be born in America. And so today, as we gather, I want to talk, I'm so glad that we're going to be talking about how vaccine has saved our lives and saved so many lives throughout the world, but that we must continue. We have to continue. We are this close. And so today we're going to learn more about how to do that. And most importantly, I'm really pleased that we have experts with us to talk about the similarities between polio and coronavirus, and the World Health Organization, UNICEF, Rotary International, the Bill Gates Foundation. We all together have built this infrastructure for polio. What a better infrastructure for our world to look at in eradicating coronavirus. So I turn that over, and again, thank you for being with us today.
Thank you, Peggy.
Every child deserves to live a life free from polio, no matter who they are, no matter where they are born. Many barriers can stand between a child and a vaccine: challenging terrain and weather, rumors about vaccine safety, weak health services, conflict and insecurity. Alongside the partners of the Global Polio Eradication Initiative, the World Health Organization ensures that all families can access polio vaccines by developing strategies to reach every single child. In every vulnerable country, the World Health Organization works with governments to help make sure polio eradication operations are planned and implemented properly so that no child is missed. Frontline health workers are the heroes of polio eradication. To ensure equitable access to polio vaccines, they climb mountainsides, trek across deserts, brave long journeys, and even insecurity to deliver 2 drops of vaccine to each child multiple times. By developing targeted strategies to reach every last child, previously missed children in the most at-risk areas are now getting vaccinated. This is resulting in higher and higher immunization coverage rates. Detailed plans of every city street, village, and remote settlement help vaccinators know how many children they should find behind every door that they knock upon. The World Health Organization helps identify vaccinators from within communities themselves. By training local women and men who are trusted by their neighbors and who can deliver the vaccine themselves, immunity can be rapidly built up even in villages where public services are weak. By finding and working with local community influencers and religious and traditional leaders, the World Health Organization, UNICEF, and Rotary enhance community acceptance and ownership of polio eradication efforts. Innovative strategies help to deliver vaccines even in remote or conflict-affected areas. By maintaining program neutrality and engaging local communities, experts negotiate access to conflict zones and carry out rapid vaccination campaigns when security allows. Strategies to reach children on the move are also taking the program much closer to eradication. Millions of children are vaccinated at permanent transit points as they move in and out of insecure areas with their families. Special teams work to trace the movement of nomadic families so that children can receive multiple doses of polio vaccine no matter where they are. In some countries, polio campaigns even offer vaccination to cattle for veterinary diseases to encourage nomadic people to attend. Thanks to all of these incredible efforts by people all over the world, we can stop this disease once and for all and make sure that no child is left behind. Find out more about the global drive to eradicate polio at www.polioeradication.org.
Our first speaker this afternoon is Michelle Zaffron, who is Director of the Global Polio Eradication Initiative for the World Health Organization. We are very privileged to have him with us this evening. Before 2016, he was coordinator of WHO's expanded program on immunization and coordinated efforts for the introduction of the inactivated polio vaccine and the strengthening of routine immunization as part of the Objective 2 of the polio eradication endgame strategy. From 2008 to 2013, Michelle was the director of Project Optimize, a WHO PATH collaboration aimed at catalyzing a shared vision of the future of immunization logistics and supply chain systems. Michelle Zaffron joined WHO in 1987 as a technical officer in the area of the vaccine cold chain and logistics. He has held several positions, including program manager of the vaccines and biologicals department and coordinator of the team overseeing vaccine quality, management, and procurement. He represented WHO in the working group that designed and launched the Gavi Alliance in 2000 and held the position of Deputy Executive Secretary of the Gavi Alliance Secretariat in 2006-2007. Michel is a French national born in Algeria. He holds a master's in engineering and a certificate in tropical epidemiology. Please join me in giving a warm welcome to Michelle Zaffron from WHO. Thank you. It's all yours, Michelle.
Thank you very much, Anne-Lee, and thank you for the invitation to speak to your club. I am delighted to be able to provide to you today an update of the program. As the first slide shows, the program, and you've seen in the video that you just so the program is truly a collaboration with Rotary at the center of the effort, because Rotary was the first one to actually launch this effort to eradicate polio, then followed by WHO and the other partners, UNICEF, the Center for Disease Control, the Gates Foundation, and Gavi, the Vaccine Alliance. When we started back in 1988, and the World Health Assembly, the gathering of all ministers of health in the world, decided to eradicate polio, 125 countries were faced with endemic circulation of the polio virus. And 350,000 children were being paralyzed every year. That's 1,000 every day. Today, we are facing only 2 countries with the remaining wild poliovirus endemic circulation. This is the lowest in history. It's a considerable achievement. The achievement also that we actually celebrated this year in August is the fact that the African region was certified free of wild poliovirus. This was a true achievement, given the fact that we were facing challenges in northeastern Nigeria where a pocket of population was inaccessible to the vaccinators, and the virus was surviving in this area because of, you know, insurgent groups that actually prevented vaccination and prevented the entry of vaccinators. Nonetheless, the program was able, thanks to all of its efforts and thanks to efforts of Rotarians also in Nigeria, to actually avoid first that the virus escapes this area, and that could actually lead to sort of an infection of other African countries, but also eventually eradicate it. So that's an extraordinary achievement. This is the global picture of the polio cases over the past 6 months. As you can see, there are red dots only in Pakistan, Afghanistan. This is the wild polio virus that continues to strike in these two countries. But we unfortunately also have outbreaks of what we call circulating vaccine-derived polioviruses. And they are mostly in the African region, although we also face them in Pakistan and Afghanistan. In Afghanistan, we have ongoing circulation of the wild poliovirus. 129 cases in both countries over the as of this date, and that's 88 compared to 88 during the same period of the year last year. We have persistent transmission in core reservoirs of Karachi. This is here, and the Quetta block in Pakistan, as well as in the southern part of Afghanistan. The expansion of the transmission to previously polio-free areas, such as North Sindh and South Punjab, Pakistan, as well as in the west and north region of Afghanistan. So unfortunately, the situation has deteriorated substantially over the past several months. And on top of that, we have also circulation not only of the wild poliovirus, but also of the vaccine-derived poliovirus. So why do these outbreaks continue to occur? The situation is that we have low population immunity to the type 2 virus. We have declining immunity since the switch, what we call the switch from trivalent oral polio vaccine to bivalent oral polio vaccine that we organized back in 2016. The outbreak response campaigns that we're conducting probably are not at the high enough quality to actually ensure that all children get vaccinated. But on top of that, the vaccine that we're using is a vaccine which in rare cases, but in some cases, can actually sort of, the virus that is contained in this vaccine can actually sort of become, through genetic mutation, become again virulent and seed new outbreaks in areas not among the children that are vaccinated, but precisely again among the children that are close to the vaccine, to the children that are vaccinated, outside of the vaccination area. So what are we doing? We're developing a strategy. We have developed and we've launched a strategy to actually address this problem. The first pillar of this strategy is, of course, to do better quality campaign. The third, and I'll come back to the second one afterwards, the third is actually to strengthen a routine immunization system. And the fourth is, of course, to ensure that we have enough vaccine. But the second one, which is key and is going to show result pretty soon, we hope, is to actually develop and then roll out a novel oral polio vaccine type 2. This is a new vaccine specifically designed to avoid the problem that we're facing now with the vaccine, with new outbreaks being seeded outside of the vaccination area. This is a vaccine with improved genetic stability that will decrease the risks of new vaccine-derived outbreaks. WHO is reviewing this vaccine and will soon issue what we call a recommendation for emergency use listing, so that this vaccine, in the context that we have, which is a public health emergency, this vaccine can be used before it is fully licensed by the countries that ask to use it. So it sort of helps us roll out a vaccine before it is entirely fully licensed by the manufacturer. The production is already underway, and we expect to actually have 200 million doses of this vaccine available by the end of the year, so that it can be rolled out in the countries where we have the outbreaks. And you've seen on the map that quite a few countries are facing these outbreaks. Now, the pandemic, of course, has had a huge impact on the world, is having a huge impact on the world, but also has had a big impact on the polio program. When the pandemics started to strike the world, in many of the countries where we have staff, it was quite rapidly obvious that our staff needed to support the response to the pandemic. So they were involved in supporting outbreak response, supporting preparedness of the countries, looking at surveillance to make sure that they were able to track where the COVID virus was circulating, help trace contacts of the cases, help also with the risk communication as well as managing the data. And they also provided training to their frontline workers who were actually going into the communities so that they could actually convey messages on infection prevention and control and themselves not run the risk of contracting the disease. On the polio program, this pandemic has had a huge impact. We've had to stop the vaccination for 3 months. And the reason is that we didn't want to carry out activities that would actually come in contradiction with the recommendations of physical distancing. And we didn't want to be responsible for further exacerbating the pandemic by sending teams to communities that perhaps did not have the pandemic yet. And so as a result, we've stopped vaccination in about 35 countries, and over 18 million children are now sort of at risk of diseases, vaccine preventable diseases, vaccines that could not be delivered during this period. We are resuming the campaigns, but in the interim, we've also had a huge difficulty in the surveillance system. We recommended that the program continues to track the polio virus at the same time that they were helping respond to the COVID pandemic. We wanted to make sure that we would be able to actually know where the polio virus was circulating so that when we're able to resume, we can resume in an effective manner. But the surveillance has been affected because the borders were closed, because people at the ground level were not able to collect specimens of children affected, or because when they had collected those specimens, they could not ship them to the laboratory. So we've had a huge impact, as you can see on those graphs that are declining trend of huge impact of not being able to do the surveillance at the same level as before. But we've now issued revised guidance to the programs because, as you can see on this graph, we modeled the impact of the pause in vaccination on the circulation of the virus. And the circulation is basically going to be exponential if we don't vaccinate the children. So we actually sort of developed new guidance to encourage the resumption of campaigns by the countries. But this resumption of campaigns needs to be decided upon a very thorough risk analysis. We want to make sure that the safety of the frontline workers and the safety of the community is paramount and taken into consideration before deciding to carry out a campaign. These campaigns should resume when only the local situation allows that to happen. We've issued a number of guidance, operational guidance for countries to be able to do that in a safe manner. But we really believe and we're supporting countries to ensure that they resume as soon as is safe to do so. And as you can see on this map, the campaigns are indeed resuming. We've planned a number of campaigns in Africa, but also in Afghanistan and Pakistan. And those campaigns have taken place in Pakistan and Afghanistan already in July, and new campaigns are being scheduled for this month as well as the next month. So what's next? Obviously, the program needs to set priorities for the next 6 months, and those priorities are obvious to everybody. First, we need to finalize the transformation of the Pakistan program so it can really tackle the disease. It is really the remaining country. Afghanistan, of course, is affected, but Pakistan is the main problem for the eradication of polio. If Pakistan manages to eradicate polio, quite rapidly, circulation in Afghanistan will also stop. So we need to actually ensure that Pakistan sort of is fit for purpose. We also need to resume the activities as soon as possible. And that's not so easy because the COVID pandemic is, slowing down in some countries, but resuming in other countries. So it's actually quite complicated. We need to, for the outbreak countries, safely continue the response to the campaign with the current vaccine. But as soon as WHO issues an emergency use listing recommendation for the novel vaccine, we will roll out this vaccine so that we can actually not only stop the outbreaks, but also avoid sort of emergencies of new outbreaks. Financing remains a huge challenge. uh, given the pandemic, given the continued circulation in Pakistan and Afghanistan. So we actually are launching a big effort to advocate with countries, both the endemic countries and the outbreak countries, so that they also themselves contribute more to the program. We also are reviewing and scrutinizing everything that we're spending to make sure that we don't spend something just because the funding is there, because we actually need to be extremely cost efficient. And we're advocating with all donors to secure additional funding. We need to continue to work together, all 6 agencies with Rotary at the center for a polio-free world. This is the little Luis Fermín Tenoria, who was the last kid in the Americas, in Peru, who was paralyzed by polio back in 1991. This is the last kid, Mom Chanti, a little girl who contracted polio in 1997 in the Western Pacific, the last child to be paralyzed in that region. This is Melik Minaz, who in 1998 was paralyzed by polio in Turkey. And that was the last kid to be paralyzed in the European region. And this is Ruchar Khatun, a little girl in Southeast Asia, in India, who in 2011 contracted polio. The last girl in India, the last kid in India to contract polio, an extraordinary achievement. And thankfully, we now have Yafana Hali, who contracted polio in Nigeria in 2016, but she was the last girl, last kid to actually contract the wild poliovirus in Africa. And this is an extraordinary achievement. So now we need to do the remaining work that will lead us to eradicating polio also in Pakistan and Afghanistan. I thank you very much.
Thank you, Michelle. Much appreciated. All right, everyone, if you would please, any questions that you may have for Michelle, if you could start putting those in the chat now, that would be useful for when we get to the panel. And I'm sure you'll have many questions, even though Michelle was quite thorough in everything that's going on. So we're going on to the next one.
Now, future generations of African children can live free of wild polio virus.
Now I'd like to welcome Dr. Tunji Funcho, who is a member of the Rotary Club. I hope I'm pronouncing this correctly, Tunji Like Faze in Lagos, District 9110. He used to belong to the Rotary Club of Kano, which is in the northern part of Nigeria. Tunji is a physician, cardiologist, and healthcare consultant. He worked with the Kano and Lagos state governments from 74 to 76 before going to the UK for his postgraduate specialization in medicine cardiology. He returned to Kano, to practice with the state government until 1985, when he retired into private practice. Dr. Tunji was a district governor from 95, 96, and he was a state Polio Plus representative Polio Plus Chairman, Rotary Foundation Grant Subcommittee Chairman, a district trainer, and a member of the District Strategy Committee, as well as a delegate to the Council on Legislation in 2001. As stated earlier, he was a district governor in 95-96, and he has held many various offices, such as a Regional Rotary Foundation Coordinator in 04-07, and many other similar positions throughout Rotary. Dr. Tunji has been extremely, extremely active, but nothing has been as important as what he's doing now, currently serving as chairman of Nigeria's National Polio Plus Committee. He's also a member of the Africa Regional Polio Plus Committee. He's a member of Rotary's International Polio Plus Committee, a member of the End of Polio Subcommittee, and Award Subcommittee of the IPPC. He has been instrumental to several major projects in the club and districts locally. He is also instrumental to the formation of the Rotary Leadership Institute Nigeria Division, and was chair of the Nigeria Division for 5 years. Dr. Funjo has received numerous recognition awards, including Rotary International Service Above Self Award and the Rotary Foundation Meritorious Service Award. He is a second-level major donor, a Rotary Foundation benefactor, and a keen golfer. And he's married to a wonderful woman, Aisha, and they have 4 children and several grandchildren. Dr. Tunji, I welcome you. Please join you, everyone from District 77A, in giving a warm welcome to my friend, Dr. Tunji Funjo from Nigeria. All yours, Tunji. Did we lose him?
I don't see him anymore.
Uh-oh.
I see him.
I see him, but he's on mute.
He needs to unmute. There we go. Oh, try again.
There you go. Tunji, it's all yours. I can't hear you, Tunji.
Can you hear me now?
Yes.
Great. These are the kind of things that crop up from time to time, on these meetings. Thank you very much, Anli. I think I must, commend you for your steadfastness as far as the polio eradication program, is concerned. We miss you in Nigeria. As most of you know, Lee has been in Nigeria quite a number of times, helping to boost our morale and give support at the grassroots level for polio immunization. I want to recognize IPPC Chair Mike for the tremendous work he has been doing to leading us in the past few years to ensure that Rotary remains on track as far as our effort to eradicate polio is concerned. Now, first slide is just to remind us of, can we have the first slide, please? It's just to remind us of, the whole purpose of this exercise. What we have been doing, what we keep doing now, and what we need to continue doing well into the future. Back one slide, please. It's to get those precious drops of the oral polio vaccines to the mouth of our children. Whatever we do, whether it's advocacy, whether it's fundraising, whether it's creating awareness, whether it's actually being in the field prepared for this activity, it is to ensure that no child is missed with the oral polio vaccine. The next slide is to congratulate us, Rotarians, for the tremendous efforts we have put in to ensure that Nigeria become polio-free, and by extension, the rest of the Africa region pronounced polio-free by WHO on the 25th of August this year, after just about 4 years, as was reported in that Dr. Moeti's short video clip. I think Rotarians in every part of the world have played various roles at different levels to ensure that we get to this very important milestone. And I want to say thank you to all of you. Now, lessons learned is what I've been asked to talk about. I'll try and make it as brief as possible. I think one of our earliest obstacles, next slide, is the fact that we had a lot of resistance to vaccination, particularly for polio vaccination. I think apart from some of the negative mischievous claims about the danger of the vaccine, I think we're a little bit presumptuous that once you are bringing something good to people, they'll accept it with open arms, without questions. And cultures differ everywhere. And it took us a while to realize that though we're doing something good, we need to make the population who are at the receiving end of our efforts to understand why they require the vaccines and what purpose it will serve both in the short term and the long term. I think we got that right eventually when we now got to be able to communicate with the leadership at the grassroots level, particularly the traditional leadership and the religious leadership whom the people trust and respect. And that led to the gradual acceptance of the vaccine. The second thing, and I'll talk about that in a little more detail when we talk about kick polio out of Africa, is that you cannot shave a man's head in his absence. We needed to have a buy-in of the governments and also the beneficiaries of the vaccines themselves. In other words, we need to ensure that we communicate adequately to the government about the need for them to be involved. And then to the communities about why their children need to be immunized and the dangers of not having their children immunized. The third thing that we learned is that disease eradication costs a lot of money. And polio has taught us that we must keep the budget line open at any point in time. I know a lot of Rotarians now are asking questions. We started with a budget of $120 million in 1985. Though we surprised ourselves by raising almost twice that amount, our budget has ballooned to almost $20 billion. But thankfully, Rotary has contributed 2.1 billion of that amount of money. That's a huge difference. And to make this easier for us, I think we need to continue making Rotarians anticipate the fact that we may need more money to get to the end of this polio eradication project. Particularly now, we need to focus our attention on Pakistan and Afghanistan. Next slide, please. The next thing is that every creature is designed to survive in times of adversity. And that is what the virus has been doing to us. The polio virus has found ways of protecting itself, either due to, like we have seen, mutation in the case of vaccine-derived polio virus, or finding itself in environments where it is difficult to reach it and get rid of it. And so in our future plans for situations like this, we need to bear this in mind so that the scientists will find a way of fighting whatever the disease we want to put our efforts into, to be one step ahead of the virus or whatever the infective agent is. We've also learned that technology is a great ally in disease eradication. In the last phases of our efforts in Borno State in particular, and in Nigeria in general, technology has been a huge asset for our effort. One, it has helped us to have much better quality mass immunization campaigns, what was referred to as supplementary immunization activities by Dr. Michelle Zafran earlier. Because now we can ensure that with technology, vaccinators reach every household that has been mapped to be reached. The second area technology has helped us is in recent times in Borno State in satellite imaging to be able to identify those areas that are no more populated by children so that we do not waste our efforts in trying to reach those areas. Rather, we concentrate our efforts in those areas that through satellite imaging, we have confidence that there are children there, and then we'll bring forth such innovations as reaching every settlement, which is efforts using the military to actually go into insecure areas and vaccinate children. But I think the major lesson for us is that no challenge is unsurmountable when people of like minds get together, focus on an ideal, and are tenacious about it until the end. I think despite all our challenges, despite how long it has taken, despite how much it has cost, Rotarians and partners have stayed the course. And that is why we have gotten ourselves to 99.9%, of our efforts. And having been able to eradicate the type 2 and type 3 wild polio virus, the same kind of efforts, the same technologies will assist us in ensuring that we get to the end of this efforts through the eradication of the wild polio virus type 1. And of course, with an eye on the vaccine-derived polio cases. Now, when I said, no, you cannot shave the man's head in his absence, the next slide is referring essentially to our Kick Polio Out of Africa initiative and campaign. Now, this was an initiative, as a matter of fact, by Rotary. Rotary President Herb Brown, 1995, 96 president, had approached Nelson Mandela to lead a campaign of African leaders to start mass immunization campaigns. Until 1996, despite the fact that the GPI program started in 1988, not a single African country has embarked on mass immunization campaigns. That effort of Herb Brown culminated finally in a meeting of President Louis Giaye and blessed memory, and Trustee Raja Sabu, the press conference after the OAU meeting to initiate this famous Kick Polio Out of Africa initiative. At that time, if you recall, when Michelle was telling us about the ravages of polio in the 1990s, 70,000 children were being paralyzed by wild polio virus. That initiative got 30 African countries within 1 year to start mass immunization campaigns. And from then on, more countries joined in mass immunization campaigns that finally got us to where we are today. Africa free of the wild polio virus. The other lesson learned, as I mentioned, is that this initiative costs money. And Rotarians will ask us, Africa is now free of wild polio virus. Why do we continue asking for money? The reason is simple, is that many African countries still need support to ensure that routine immunization continues, and also to ensure that mass immunization campaigns, that is the house-to-house campaign, continues. And they need money, as I mentioned earlier. But then the next slide just gives you an idea of the relative amounts of funds we spend in the different aspects of this endeavor. And you can see that from campaigns and surveillance, we spend almost 60%. Campaigns are important to bridge the gap of the number of children who are suboptimally immunized because they have no access to routine immunization. And surveillance is key to any disease eradication process because you cannot, number one, say a disease doesn't exist anymore except you are actively searching for it. The second thing is that if you do not detect it early enough, then it will spread and you have a new problem on your hand. these are very, very vital areas that the funding are going to continue being expended on in Africa and in most parts of the developing world, including the current areas that are still polio endemic. That's the Emerald region, particularly Pakistan and Afghanistan. So, next slide is just to remind us about the Gates March. That we need to continue raising funds to be able to meet the Gates challenge of matching each dollar we spend with $2, up to 50 million US dollars annually. Thankfully, we have an extension of this agreement till the year 2023. So essentially, we are looking at Rotary spending with the Gates Foundation match 450 million US dollars through to 2023. But this is just a bit of what we require, because next year alone will require almost $1 billion US dollars, according to the recent budget. So I want to admonish us, next slide, to continue to contribute to the Polio Plus Fund of the Rotary Foundation and participate as much as possible immunization activities. If you can, travel to Africa, we'll still be doing campaigns. Pakistan, Afghanistan will still be doing campaigns. Thank you, Anli, for all your efforts in this regard. I was just looking at some images of you in Abuja recently. And please, at least all of us can do it in our own ways with the advent of social media, promote the need for world eradication of polio and also the need for us to make funds available. And just to remind us that World Polio Day is next week, and I'm sure all of you are getting involved in one way or the other in promoting different aspects of our efforts in polio eradication in the next week going into 2 weeks. So what we must continue to do, next slide, in summary, is advocacy to Rotarians, to governments, and to caregivers. Continue to create awareness and mobilize the community so that they demand for the vaccines, increase our routine immunization coverage, and like I said earlier, continue to raise funds. So next slide is just to remind us that, Africa, is wild polio free. We need to keep it that way. And the way to keep it that way is to continue immunizing every child that is born and every child below the age of 5. But in a COVID-19 era, be aware that we need to keep safe and well by staying at home if we don't have to go out. But if we have to go out, we should wear masks and to wash our hands regularly and use hand sanitizers as much as possible when hand washing is not possible. So thank you very much. I know I've overspent my time by a few minutes, but sometimes I can't help myself talking too much.
It's okay.
About polio eradication. Thank you very much indeed. Thank
you, Tunji. Please, everyone, if you have questions for Tunji, please put them in the chat now, and we will get to them right after the panel, when it's time for the panel. Tunji, thank you very much for your presentation. I always enjoy your African proverbs. And I wanted to also recognize you for, or honor you for your recognition with Time Magazine. So congratulations on that. Okay, so moving right along, we are going to
This is the story of historic progress, a story that doesn't exist without you. Our unifying effort in 3 decades of action demonstrates our commitment and endurance. And our progress thus far shows that a polio-free world is achievable. Individuals, clubs, partners, and governments share a collective vision to improve the health of every single child. We've eliminated polio in some of the most difficult places, overcoming obstacles and navigating complex issues. Our successes prove that polio will be eradicated, and while ending a global disease is not easy, as Rotary, we don't give up. We'll continue our fight until each child is protected. This isn't possible without you. So stay involved, keep pushing forward, engage your clubs and communities, start a social media conversation, and increase visibility on the importance of this global effort. Hold events and fundraisers on World Polio Day and throughout the year. Advocate to governments about the importance of supporting polio eradication. Make a contribution and invest in one of the largest health initiatives ever. Be a character in our story. Be the solution to our challenge. It's because of each and every one of you that we will improve our future by making polio a disease of the past. Eradication is possible. So let's keep our promise.
And that is a perfect segue to our next speaker, who is no stranger to us. It's our own Michael McGovern from the Rotary Club of South Portland, Cape Elizabeth. He joined Rotary in 1986. Today, Mike serves as the chair of Rotary International's Polio Plus Committee, and he's been the chair since 2014. And in this role, he is the volunteer leader of Rotary's largest humanitarian project, the global eradication of polio. Rotary is indeed the spearheading partner of the Global Polio Eradication Initiative and has donated over $2 billion to ending polio, and has worked with other partners to reduce the number of polio endemic countries from 125 in 1988 to just 2 today. Mike completed a 4-year term as trustee of the Rotary Foundation, and he represents Rotary on the Polio Oversight Board of the Global Polio Eradication Initiative. He's also the incoming chair of the Rotary Leadership Institute, an independent association of Rotary districts. His entire career was with the town of Cape Elizabeth, Maine, beginning as an intern in 1977 and serving as town manager from 1985 to 2016. Please give a warm welcome to our own Michael McGovern.
Thank you very much, Annalee. Wonderful to be with everyone. Trying to get my slideshow started here. Here we go. And thank you, Annalee, for inviting me. Particularly, would like to say hello to Michelle Zaffron, joining us from France today, and Tunji as well from Nigeria. It's not easy to be doing these Zoom calls in different time zones, so appreciate their being with us. I'm going to just give a very brief update today. And mainly what I want to focus on, though, is how Rotary decides to spend money in specific areas for polio and how that process works, because I think there's a bit of a mystery to it. You know, we have had impact from polio eradication. You know, you just look at these numbers on this spreadsheet, and you know, it always amazes me every time I see the statistics that the CDC and the World Health Organization put out, saying there's 19 million people walking on this earth who would otherwise be paralyzed if Rotary hadn't had the vision, perseverance, the passion to get this started back in the mid-1980s. You know, we often hear that when it began, there were 350,000 cases a year. Well, you know, there's a lot more kids today than there were back then. So now the estimate is 650,000 cases are avoided each year. You know, 3 billion children have received the oral polio vaccine. And you just look at the statistics last year. 430 million children were working in over 40 countries. 1.2 billion doses of oral polio vaccine. You know, it's, you know, we're down to the 2 countries. The last country outside of Nigeria and the 2 endemic countries was actually Somalia 6 years ago. And, you know, as Michelle explained, we've also helped to avoid other we've also helped with other diseases. So, you know, where does, you know, Tunji showed a slide of where the whole partnership spends money. This is how the Rotary donations were used in 2019, 2020. You know, the blue, getting vaccines to children. Sometimes you hear of the cold chain and people tend to think, you know, oh, those are the coolers. But, you know, it's more than just that. The cold chain, the getting vaccines to children, it is the coolers, There's refrigerators, there's Campbell's, there's car rentals, but most of that money is spent on giving small stipends to community-based vaccinators. They're the people that actually deliver most of the vaccines. Vaccine itself is a little under 20% of the cost. You know, for a few years, we weren't spending much on vaccines because other donors, that's all they wanted to spend money on. But that's changed. The vaccine costs have gone up, particularly as we've had these outbreaks of the vaccine-derived cases. Michelle mentioned detecting disease, surveillance. Tunji mentioned it as well. You know, that is, you know, all of these places scattered, particularly across Africa, where people will take their children in, you know, they have some sort of paralysis, and they take fecal samples, and they go to labs, they're tested, and that's how we identify where polio is, as well as helping people identifying other diseases as well. So it's a very important part of what we do. But you know, you look at that gray block, and we hear in the COVID context of, you know, people going to take the vaccine if there is one. You know, you read the statistics, and you know, it's a little bit scary, but you know, situation is what it is. But you know, in the countries in Pakistan and Afghanistan and in many places, particularly in the northern section of Nigeria and other places, you know, you really had to convince people to take the vaccine. And we call it social mobilization. It's things like the billboard that Tunji showed. It's you know, it's radio ads. It's what we call organizers, even something called town criers. People that convince people in their own communities of the importance of the vaccines and of doing work. We also fund a little bit of research. So yeah, I probably shouldn't be showing this because it's actually only going to the trustees this week. I see Brenda Cressy on the call, one of the Rotary Foundation trustees. Usually recommendations that go to committees, we don't have go and present them otherwise. But, you know, it's my own district, so no one's watching other than good friends. So anyway, so every year, you know, we look at how much resources we have available because of donations from Rotarians. The goal every year, as Tunji mentioned, is $50 million a year. We also get a match from the Gates Foundation, 2-to-1. That's $100 million. So every year, Rotary has $150 million to contribute to the GPEI, the Global Polio Eradication Initiative. So what happens is, you know, they have regional offices, both WHO and UNICEF, and they put together grant requests. First of all, there's a whole budget for the whole entity, which is a little, as Tunji mentioned, is a little under $1 billion. But they put together grant requests to Rotary, and you know, they're for the things listed here, generally. And you know, we have them reviewed first. You know, Tunji, any money we want to spend in Nigeria, Tunji sees it. He gives advice. The same thing for Aziz Memon, who is our chair in Pakistan, and so in so many other countries as well. Those recommendations, along with the requests from WHO and UNICEF, go to a couple of staff members in Evanston, Carol Pandak, who's our polio director, and Veronica Gonzalez. They look at those requests. They make sure that they meet our standards for grants, and then they go to a grants committee, which is a subcommittee of the International Polio Plus Committee. That's chaired by a woman in United Kingdom, Judith Diamond, who is also responsible for advocacy worldwide. Tunji himself this year has joined that committee. He wasn't on before because, you know, a lot of money was going to Nigeria, and we kind of wondered, but you know, now that they've certified polio free, his wisdom, his expertise is wonderful. The third person is John Germ, a past president of Rotary, who's in charge of fundraising for Rotary. So, you know, in having those people in the committee, we have someone who knows advocacy, knows what countries care about. We have Tunji, who's an expert in the field, and we have John Durham, who's raising money for Rotarians. It's important that he have input. But anyway, they look at the recommendations, they reduce them to the available money. We do it 3 times a year. So the group has been meeting the last few weeks. The polio committee actually met yesterday, and we recommended $50 million, the first of 3 tranches. go to the trustees, including Brenda, and they will be making a decision this week on whether or not to actually give final approval to the grant. And you look at this, Africa, Tunji mentioned, we still need to continue that surveillance. We need to make sure that Africa stays polio free. We just can't walk away from that. So that is why $6 million, UNICEF, technical assistance, that's actually carrying out the program and the continued immunizations we need to do. We still need a social mobilization, convince people. The Eastern Mediterranean region, that includes Afghanistan, Pakistan, Syria, Libya, Iran, Iraq, all these countries. There's about 24 of them, I believe, maybe 22. So we're continuing surveillance there. We're doing it in Afghanistan. We're paying for the National Immunizations Day. A lot of the next 4 or 5 you see here, it is all about providing money for the vaccinators, the stipends, for the transportation, for all of the operational activities to actually carry out the program. So when you hear there's a National Immunization Day in Pakistan or Afghanistan, Rotary is a big piece of actually paying the expense of that. It's carried out by the governments there, but with direct oversight by WHO and UNICEF. But also, we have Rotarians in those countries who are out there during every immunization activity, making sure that they're going smoothly, making sure our monies are spent. And we also have Rotarians afterward who review to make sure the money was spent where we intended it to be spent. We're helping with the outbreak response. MOPV2 stockpile, that is, we're having to fund vaccines. That's 12.3 million to make sure that we can deal with these outbreaks. And as I mentioned earlier, we're also funding research. But this is, we do this 3 times a year. The money is crucial in ensuring that we eventually get to a polio-free world. The woman on the left, by the way, Eliza Alordo, she lives in the Manila area. And this was an activity I actually was able to go to last November, Thanksgiving Day, I think. And they had one of these vaccine-derived outbreaks in Manila. And the Rotarians, you see all the ones in the background, were out there helping with the health workers to do it. So, to get this done, we need to continue to advocate to the governments. We need to raise the money. We need to stop these vaccine-derived cases. You can get more information on these websites. But, most of all, we need to convince the people in the individual communities that it's important to have their children receive the oral polio vaccine. That is what we need to do to get this done. We need to make sure that they don't think it's just Rotary's program, they think of it as their program. This particular woman here in this picture, this was in Abuja, Tunji. You took me to a health center, and she came in at the very last minute.
That's right.
And there was a polio activity there, and she was all nervous, she was late, and we'd actually put the things back in the refrigerator, the vials, but we took them back out, and they said, Michael, you do it. So I went over, and sometimes you wonder why you do this. You look at that woman smile. This baby was just a few weeks old. She was so she wasn't one we needed to convince. She was absolutely convinced already. But if every mother was like this one, we'd be rid of polio immediately. So I want to thank everyone. Wonderful to be with you, and I look forward to being part of the panel answering questions. Thank you, Ann-Lee.
Thank you, Michael. Much appreciated. So please, if you have questions for Michael, please put those into the chat as well, and we will go to that shortly. In 1 second here. My apologies. Here we go.
نیاز می بود که به خاطر از این تقاضا داشتیم کار کنم که جلوی شیوعی مریضی مثل همی پولیو گرفته شده تا جان عزیزان ما را، پدرها مادرها یا حتی اطفال یا جوانای دیگرتن هر دقیقه و هر ساعت برشان یک خطر است. احساس برم بود خدمت کنم برشان. حالی هم کوشش میکنم حتی آقای مادرها را بلند میبرم تا بتوانم با امی کار حداقل جان طفل و همون فامیل و همون مادر نجات دنبال میکنم. تغییرات در این میبینم تغییرات رو خیلی طبعا تغییرات هم در کمی در اوایل میترسیم که مثلا همین ویروس انتشار نکنه، ولی و دیگه یک امیدواری به این دارم که چون مردم خودشان ما برشان میگیم اونا کسایی هستن که درک میکنن و این کار عملی انجام میدن خوش میشون، امیدوار هستیم که این ویروس هم بازترین وقت از بین بره. چون ما هر جای رفتیم برای هر مادری که رفتیم گفتیم با پیشانه باز قبول کرده و بر روز بعد که رفتیم دیدیم همون کار انجام میده.
I hope you've enjoyed the videos. They're also quite informative. So let's start with our questions. And I think the first one I'm going to ask Michelle, because it's been listed there several times. Could you speak to us about vaccine-derived polio, exactly what it is and how it's going to affect our program long-term in regards to reaching our goal? And at what point would the OPV change over to the injectable?
Well, that's a lot of questions. And
well, pick one.
So the most important thing to remember is the vaccine we use is a safe vaccine and effective, and it has taken us this far, which is, you know, the 5 out of the 6 regions of the world have been certified free of wild poliovirus. Now, this vaccine that we're using, which is working so well, in some very rare cases can actually, the virus that is contained in this vaccine, it's a weakened virus. We've taken the poliovirus, we weaken it, or the manufacturers have done that, and that's how it's protecting children. In some very rare cases, and that happens when many children are not vaccinated. You use the vaccine to vaccinate a group of children, but you miss many children, or children don't want to be vaccinated. And then the vaccine virus will be transmitted from child to child through fecal oral transmission, as a normal polio virus would be transmitted. And in those passing from child to child, passing from child non-vaccinated to child non-vaccinated, it will mutate. It will actually sort of change and become dangerous again. So in rare cases, we can have outbreaks caused by the virus that was initially weak, but has returned to actually becoming dangerous. And these are the vaccine-derived virus. It's important to remember that it's not the child who is vaccinated who gets paralyzed. It's the child who is next door or next district or a kilometer away from the child who was vaccinated, and not the first one, but probably the 100 or 300 one or 1,000 one that actually, you know, got the virus that had the chance to actually mutate. And I mentioned this novel oral polio vaccine, which is a vaccine which is being developed. The development of this vaccine started 10 years ago, and we're just about to have it available. And this novel oral polio vaccine will indeed be a vaccine which is genetically much more stable and not have this problem of basically sort of running the risk of becoming virulent again. The virus inside will not become virulent again. It's much more stable. So we hope to be able to start using this vaccine before the end of this year and then roll it out gradually to all countries that are facing those outbreaks.
Thank you. You did very well. There was a lot of questions. One quick question. Does the Novel vaccine have to be refrigerated the same as the others?
Yeah, it's very similar to the one we have at the moment. It's only a few mutations and genetic mutations that have been done to avoid that the virus could actually become virulent again. What I did not address in your question is the injectable vaccine. We've already he introduced worldwide in the country that we're working with, 1 dose of the injectable vaccine. So Nigeria has 1 dose, and all countries have actually at least 1 dose. Many countries, only use this vaccine, but the poorest countries at least have 1 dose. And thanks to the program and to Gavi, which is now a partner in the initiative, all countries will have accessible to a 2nd dose. For a child to be fully protected against polio, the child needs to receive 2 doses of this injectable vaccine. He will receive 2 doses of the injectable vaccine starting from next year, but we'll continue to receive the oral polio vaccine, which is indispensable to stop the transmission from person to person. Eventually, what we want is actually use only the injectable vaccine, but that will only be done when we have fully eradicated the wild virus in Pakistan and Afghanistan. We cannot stop using the oral polio vaccine before we fully eradicated the wild virus. And therefore, also children in Africa and children in Asia need to continue to be vaccinated with a vaccine.
Perfect. Thank you very much for that explanation. My next question is open to whichever one of the 3 of you would like to make a comment. Rotary and GPEI have a lot of experience combating mistruths about vaccines. So as the world prepares for a much needed COVID-19 vaccine, there are many inaccurate statements about vaccine safety. They're abounding everywhere. What do you feel are the best practices to overcome this harm and to educate the public about the science and the truth? Mike, you alluded to this a little bit.
Tunji may want to comment from his experience in Nigeria, because Nigeria has been facing lots of difficulties with rumors.
Tunji, you want to unmute and give us your opinion there?
Okay. Yes, I'm glad to contribute. One of the things, I mentioned earlier about, some of the lessons we learned, is the issue of, assuming that if we bring in something safe, according to us, our belief, our understanding, to people should accept it with open arms, not minding that there are negative news in the circulation about this good thing we are doing. And I've always been a proponent of selling vaccines, on their own merit, rather than engaging negative, media responding to negativity. And a lot of people don't actually realize, like Michelle said earlier, the NOPV is taking a decade to develop. A lot of people don't appreciate that. They don't know what it takes to bring a vaccine to the market and why it takes so long. If people realize that the reason it takes so long is to ensure, 1, that is, efficient, 2, it does little or no harm at all, it'd be much easier for us to convince them. But this is not in the public domain, that vaccines are safe because of A, B, C, D. They are told by us it is safe, but there are other people who are out there very well equipped to demarket vaccines. And a lot of people don't check on what they read. They just, swallow conspiracy theories, hook, line, and sinker. So I think we need to sell, vaccines more. We need to propagate how vaccines come into being, how long it takes, what kind of work goes into it, and who are the people who actually take the decisions about the safety of vaccines. We can see the kind of thing that is going on, about the COVID-19, vaccine. I think people are now realizing, that there are processes, though, politics is affecting that in some way, but people are realizing that, vaccines are not just like going to prepare a cup of tea. It goes through a process that is reviewed by peer groups of scientists who are independent people who have no financial interest in the outcome of the product. So we need to do a little bit more work in that regard. That's my contribution.
Thank you, Tenji. Thank you. My next question is from someone, and I'm not sure who would have the answer to this. It's a two-part. How many children in Afghanistan and Pakistan were contracting polio in the mid-1980s as compared to today? And how many children are there in Pakistan and Afghanistan? Does anybody know the population numbers? Michelle, maybe?
I don't know it by heart, unfortunately. I can dig up the data and send it to you.
Okay, I would imagine in the mid-80s there was a fair amount of polio, though.
Sure.
Yeah. Okay.
You know, Afghanistan is a country which, of course, had polio and had quite a lot of polio, but it's a country where the population density is not very high.
Mhm.
It has already eradicated polio twice in the past. In 2016, it totally stopped transmission of indigenous polio, but it got reinfected from Pakistan because of the population movement. Now the genetic enables us to see where the source of the virus is, and it's clear that Afghanistan can stop polio circulation quite easily in spite of the war, in spite of the difficulties, because the population density is not that high. But it shouldn't be reinfected. And that's why I'm saying it's so important to eradicate in Pakistan.
Perfect sense. Thank you. Mike, I see you unmuted.
Yeah, Anley, I don't know the exact numbers, but my recollection is that one of the recent NIDs in Pakistan, you know, we target, that's not a good word, but we seek to serve, I think it was 34 million children under 5 with the polio vaccine in the most recent NID.
Okay, thank you.
For Pakistan, for Afghanistan, I have the numbers now. The population of Afghanistan is about 38 million, the total population. So that's the surviving infants. The population less than 5 is about 5.6 million.
Okay. And you're right, and it's not dense. I mean, it's spread out into really mountainous regions. Thank you.
Michelle, was I close with the 34 million? If I'm wrong, you know, no.
You were citing Pakistan, were you not?
Pakistan, yeah.
Yeah, and I was referring to Afghanistan. Yeah, Pakistan,
Yeah.
right, yeah, absolutely, yes.
Okay.
Okay, I don't see any other questions. I did want to make a comment, Mike. You gave a great overview on where Rotarians' money goes, and I love that. Also, the fact that you pointed out, not only do we get to spend the 50 million that Rotarians raise, is that we get to actually allocate where the money goes that the Gates Foundation matches us for, which is kind of nice. That shows the trust that they have in Rotary. And that's been very important. I don't see any other questions here in the chat, unless someone wants to write one real quick. It seems like we're at the end of discussions. So I'm going to share with you one more video, and then we're going to have a roundup, thanking our presenters, because you've all done an amazing job, and we're all leaving here with our heads just, whew, too much polio. It's great. So hold on.
No sound, Henley.
Oh, there was no sound, was there? I was muted. Sorry, everyone. Shall I do that again? Or actually, I'm going to have Peggy give the ending.
It was a good, I did see that video and I thought it was good.
Sorry, I'm sorry. I had myself muted trying to be nice to my presenters. So go ahead, Peggy. Thank you.
All right. Well, thank you so much. And you know, as I look at the attendees, we have Rotarians from different aspects of membership and past district governors and current district governors. We have individuals from France. Michelle, oh my word, it is so nice. And you know what is so good about you being with us today is that you connect for us what the World Health Organization is. We hear about the World Health Organization. We hear about WHO. For years and years and years, you have brought that personal side of that organization to our collaboration. And I can't thank you enough for doing that for us. And Dr. Tunji, here you are, sitting in Nigeria. We here in southern Maine and coastal New Hampshire, a little cooler than where you are. But I wanted to thank you for clarifying why we must continue, because we hear it consistently from our members. Why do we need to continue to fund the eradication of polio? And you just made it so much more clear for us, that we need to continue our advocacy, that we need to continue to create awareness, the need for social mobilization, and the fact that surveillance must continue each and every day, that's what our funds are important for. Michael, you reinforced that, and again, thank you for doing that, so that now we as Rotarians, when we go out and we wear our End Polio hats, and when we wear our End Polio armbands, that people, when they say to us, well, I thought there was no polio, I thought we got rid of polio. We have education behind us. We have information behind us to say, well, let me tell you what, this is really what's happening with polio. And I feel, I speak for myself personally, I hope it's the same with all of you, that, we can go out there and feel more educated about continuing to support polio. Let's just say, and that's what the last video is all about, it's that we're this close to eradication. Let's continue to work for, a polio-free world. Let's keep our promise. We've heard that time and again. And I just want to end with President Roosevelt, during his term, started the organization called March of Dimes. And what he asked was that all Americans donate their dimes and send their dimes to the White House to help with the treatment of polio victims, and for their dimes to help with researching for a cure. What that says to me, and the point I want to make, is that every dime counts. And what President Roosevelt did is he changed the philosophy behind being a donor, behind fundraising, that it's each and every dime. That's why, it's all of us, all people, no matter how small or how large the contribution. Our contributions, we hear, promoting every Rotarian every year. We, no matter how small or large, can help to form a polio-free world. Remember endpolio.org, and I want to thank all the Rotary clubs who have made a contribution to Polio Plus as a thanks for the district governor club visit this year. Thank you for your contributions. So again, Ann Lee, superb in joining us together today.
Thank you, Peggy. Thank you. And Michelle and Tunji, thank you for sharing your Saturday evening with us. We much appreciate that. And Michael, always, it's good to have you with us. And thank you everyone for attending. Peggy, well done. I'm going to let the last video run now, and you can leave as you wish. But thank you, Michelle and Tunji, so much, and Mike. Thank you.
Yes, thank you. Thank you, Michelle. And merci beaucoup, Michelle.
This close. This close. We are this close. This close to making history.
This close.
We're this close. This close. We are this close.
We are this close.
This close. This close. Changing the world. We are this close to making sure no child suffers of crippling disease ever again.
We are this close to making history.
We are this close to ending polio. This close to ending polio. We're this close. This close.
This close to ending polio.
This close.
We are this close to ending polio. All we need is you.
All we need is you.
All we need is you.
All we need is you. This close. If we don't act now, we may lose this chance forever. Help Rotary make history at endpolio.org.